OSHA says you have to provide a safe work environment free from known hazards, right? Or you have to try to mitigate those known hazards. We've known for a long time. Violence in healthcare is a known hazard. It's a known risk.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
My name is Kevin McFarland, and welcome to the Art of Emergency Nursing. And my guest today is Bill Shuler, who's been with us before and is back with us to talk a little bit about his favorite topic and one of my favorite topics, and that is workplace violence. Workplace violence is such a big deal with emergency nurses, as we all know, because we have kind of a risky job, and Bill does a lot of work around trying to mitigate that violence, trying to prevent that violence, and trying to work nurses through that. So Bill, I'll let you introduce yourself. Say hello, tell them who you are, tell them what you do.
Thanks, Kevin. Hi, everybody. Bill Schuler. I am currently working as a patient safety specialist. I've been in that role for nearly 7 years, but I've been involved in violence prevention for almost 11 now. And graciously, my current employer allows me to participate on a fairly high level with our violence prevention efforts. And we're doing some great things, and we have some great ideas coming up. Just knowing, though, that it takes a significant amount of time and energy and resources, really, if you want to do violence prevention right. But so I've been involved in the violence prevention scene for almost 11 years. And my theory and my motivation behind it, of course, you've probably heard this before, but I came to the point where there's plenty of us caring for the patient, but who's caring for the caregiver? And, patient safety is one way that I can support caregivers in their time of need, but also violence prevention, which, kind of, there's safety events, but they can affect us, differently in different ways. And that's a little bit about what I'm currently doing.
That's something that I think we tend to forget is that the after the incident is a big piece of how do we support before, during, and after. And I think we kind of forget that, and you kind of forget that, like, this can mess people up. Like, I know people who've been pretty messed up, having experienced episodes of violence, and it completely changes their trajectory. So
yep. Changes their, even their career. It can make them leave the profession of nursing, for a couple. I mean, it could be psychological, but it could also be physical.
Absolutely.
It's amazing if you dig into the numbers, how expensive, even one workplace violence injury could be. I mean, you talk about 5 figures, sometimes 6 figures for one person. And then if you think you can have multiples, you could be spending a lot on workers' comp.
Yeah. So it can get really expensive for the organization.
Yep.
And one of the things I think that not all organizations do is really focus on how do we prevent that violence? How do we train and then support the people who are there caring for the folks, whether it be the nurses, the techs, the security officers who work in the hospital, who I think are probably one of the most critical folks to train, because they potentially have the least amount of training. But I know there's a lot of organizations put a lot of work into that, but it seems like that's something that there's always some opportunity for.
Yeah. And I think everybody's on their own journey, right? Some places have the violence prevention program well established for quite a few years, and that can be influenced by, state laws, like we have on the West Coast. Washington, Oregon, and California all have specific laws for violence prevention, that you have to have a violence prevention program, including education, for healthcare. So that those have been, California's, I think, was 2012. Oregon's was 2007. and Washington State was in, I believe, the late 90s.
Wow.
So they're
way ahead of the curve.
Yeah, we've been at it for, but realizing at a few years ago, there was only 9 states that required this. Now we're up to like 13 or 14, which so public policy is helping move us forward. And the other thing is accreditation bodies, i.e. the Joint Commission, are helping move this needle forward too, because they updated their requirements for hospitals, where you actually, if you're going to be accredited by us, you need to have a violence prevention program. You need to have a multidisciplinary committee. You have to have, one person that you can name that's in charge of it. You need to report it up to your board. So there are rules now that hospitals that are accredited by the Joint Commission need to follow, specifically to workplace violence. So that's moving the needle. Other things, and what we wanted to talk about was, how do we support our leaders? One of the things that's been on my radar in the last few months to almost a year has been, I see a workplace violence program manager, a violence prevention program manager for, it could be for your hospital alone, but it could be for your health system or your region, because there's so much that we can do with violence prevention, not just, education, but looking at communication of risk, flagging, things of that nature, or even now getting into violence risk assessments of, how do you assess your patients for risk for violence, kind of like we do for fall risk or even skin assessments.
Now there's a couple scales out there that do just that. Correct. Like I don't have much experience with the scales. We've had some conversations about it and had some conversations about, standardizing this, but I don't know that I don't have a whole lot of experience. Are there multiple scales out there, and tell me a little bit about them. Have any of them been like really studied and picked apart? Would they get the Lisa Wolf stamp of approval?
I'd hope they would. But I know there is, and I just skimmed it. There's a recent article in the Gen that looks at violence risk for emergency departments, and I don't want to misquote, but it was kind of inconclusive. Yet, what I've been looking at, and the two common ones that have popped up in the literature as of late, are the Brosette Violence Checklist, or the BVC, as well as the Dynamic Appraisal of Situational Aggression, which is called lovingly known as DASA. And so at one of my facilities, we are going to trial the DASA on our behavioral health units. Both of those risk assessment tools were, I think, started in behavioral health, and then people grabbed them and trialed them in the emergency departments, and they found that they're verified and validated tools. Nice. to the point that when you use them, there is now some predictive validity to them. Essentially meaning that the higher the score of when you assess them, the higher the score, the higher likelihood that they will have some sort of episode within the next 24 hours.
I got to tell you, I mean, we all know, ER nurses tend to go with their gut. We're like, that guy is going to be a problem. They're like, that guy's going to be a problem, or that person's going to be a problem. But the reality is it is fairly predictable and fairly repeatable.
Yeah.
So I mean, then it's just a matter of getting someone to actually like study it. Right.
Yeah. And if you read in the history of violence risk assessments, and this can be non-clinical as well, it could be, criminal justice based, how likely are people likely to reoffend and things of that nature. It's morphed. It used to be mostly expert opinion. Sometimes you can use a tool plus expert opinion, where I think from what I've been reading, you take dynamic risk factors versus static risk factors. So static means it's always there. If you have this diagnosis, that's a risk in its own. But I think they're also realizing that, violence prevention or violence risk is not necessarily static. There's dynamic, there's factors that change. So I think the Brosette and the DASA both include more of the dynamic, like how are they looking right now, where you don't necessarily need to know their history or have had experience with this patient before. I think one of the studies said that if you're going to use it like a violence risk assessment tool, you would use it universally. You would use it on everybody.
Everybody gets the same.
Right.
That makes a lot of sense because you're, for a couple of reasons. One is then we get better at it. We get better at evaluating it. We get better at doing it by, the more you do it, the better you're going to get. But two, you never know who's going to get violent.
Correct.
You think, oh, little grandma's not going to get violent, but yet one of the times I got my ass whooped by a patient was a little 80-year-old woman who was just super angry and mean, had a mean right hook. So it's it certainly is something that I think needs to be universal. So
and you'll get those folks that you assess that fall outside. It's like they had a score of 0 and yet they just assaulted somebody. Or you're going to get people who score high that don't have anything happen.
Yeah.
So you can have the two ends. So yeah, a violence risk assessment tool can not only be helpful for staff, I think it helps, leadership have an actual plan. And, okay, so let's say you did a violence risk assessment on somebody, or that they've been violent before. How do you communicate that? I think that's another thing that's helpful for staff. There's one study that looked at, flagging. We'll lovingly call it flagging, but it's really trying to communicate violence risk. But flagging is a common term that we use for, our electronic health records. But one of the studies put forward that a physician knew a patient was violent and had the tendency to be violent, didn't want to stigmatize them. So they didn't do any communication or risk communication. And then that person, went on to actually murder somebody. So they use that as a case example of kind of the extreme. And I get it. As far as using a communication risk tool, you don't want to unfairly label. There's the risk of stigmatization, but then there's the flip side. If somebody's at risk, that, if these and these conditions exist for this patient or this person, they will get violent, and you don't communicate that to the next member of the care team, that sets your organization up for risk.
I may have said this story on the podcast before, but there was a patient that used to be a frequent friend in our emergency department. Was there all the time. His name was Johnny. And Johnny always had a knife. Johnny always had a knife on him. Johnny lived on the streets. He would do what he can to keep himself safe. He always had a knife on him. And I remember one of the nurses, we had a brand new nurse, was getting ready to go in and assess Johnny. And I said, hey, did you tell her to look for Johnny's knife? And they're like, she'll figure it out. And I was like, what are you doing? What are you saying? Do you hear yourself right now? You're putting somebody into a room with, and he wasn't a violent person. He would get a little angry, but he wasn't typically violent. But you're putting somebody in a room with somebody who has unpredictable behavior, probably has a knife, and not giving them a heads up that they probably have a knife. And I was like, what? Why would you even take that risk?
Yeah. It almost sounds like a form of bullying.
100%. Yeah. It's that neglect bullying of, fuck them. They'll be all right.
Yeah. I know Dr. Wolf has talked about Bowie's typology of violence, and she's had that in a couple of her studies, but there's a whole thing about organizational violence, right? The organization knows it has a problem, yet it doesn't do anything or does the minimal to mitigate the risk and make it a safer environment.
Yeah, boy, organizational violence is like her war cry.
Right.
Right.
Yeah. And there's a good argument with that. It's, like OSHA says, you have to provide a safe work environment free from known hazards, right? Or you have to try to mitigate those known hazards. We've known for a long time. Violence in healthcare is a known hazard. It's a known risk.
Yeah. So how do we support those leaders who are in the position where they have to do these things? And they're, maybe they're a new leader and they're like, I don't even know where to start. I don't even know what to do.
Yeah. Well, ideally, for your violence prevention program, you'd have an executive sponsor, right? Somebody who is knowledgeable about violence in their facility or in their system. They're willing to put in the work and even the funds to help. So, number one, that I think that is the key, because we've heard before, if you don't have a good sponsor, or your sponsor doesn't believe in what you're doing, it's not going to work. It's not going to do well. So I think one, for leaders, an executive sponsor, and an executive sponsor that is active, right? Does messaging. It's like, we're going to keep focus on workplace violence. What has happened? Are you making it part of your safety huddles, hospital safety huddles every day? We had somebody, not being afraid to call out, those type of incidences on top of patient safety incidents and, operational things. So I think an executive sponsor is key. I think other things that can help our leaders is, well, first you have to acknowledge that violence is likely going to happen. So we need a plan. So ideally, like you talked about, you have a plan before, as much as you can plan for during, right? Because during, there's so many variables. Doesn't matter what technique you train, it might not work in the moment. And then what happens after? And I think where our biggest opportunity is, how do we support not only our leaders, but our caregivers after these happen? So something as simple as a checklist of, okay, you have a caregiver that just got assaulted. How severely is it? Do you need to take them off the floor? Do they need to go get checked out in the ER or employee health? And then, okay, so they're gone. So what do you do? And typically a leader is responsible for investigating, safety incidences on their unit. So doing a thorough investigation, involving the people that need to be involved, that might be risk management, that might be patient safety, that might be, definitely security, get some of the experts in there. But a checklist can help you, identify, ensure this happened, make sure that this report got filed, make sure you started a workers' comp claim for them. And, leaders can do this for their caregivers. You don't have to necessarily rely on the caregiver to submit the the violence safety report, or even their own workers' comp claim. Even to the point of, how often do you check in with them? Do you call them, within 24 hours, a couple days, a week if they're still out? Do you offer them a ride home? Let's say there was an incident and you're like, man, this is really going to affect our staffing. And yet the caregiver is like, can I go home, or can I not take care of this patient and have somebody else, or switch? I think where we get into that is, what are the quote unquote victims' rights? Right. And it can depend on your state, or like in Oregon, if you request not to, take care of a person, you can request a secondary person. And if the facility does not provide a second person to help, you go in and care safely, you don't have to take care of that patient. And even in home health, if you've requested help and it's not offered, you don't have to go to that home and take care of that patient.
I got to tell you, that makes a lot of sense. And I'll give you a good example that happened in real time. For me, yesterday, we had a patient who got violent. And he was a 100% behavioral health patient. And and sick patient, but very much potentially violent, very much aggressive. And, we had a, 100-pound female sitter who was sitting with the patient, and she's like, I'm just not really comfortable. And I'm like, all right, let's see if we can swap you out. And it's not, it's not a gender thing, but it's like one of those, like, she was like, I'm not comfortable. And I'm like, okay, that's enough for me to say, well, let's figure something else.
And really, that's all it should take.
Yeah.
I'm not comfortable, something needs to change.
Yeah. And really, I was like, okay, well then let's swap you out with we swapped her out with another sitter that was there. And that guy was, like a 200 and something pound dude who was like, oh yeah, I'll sit and watch this guy. Not worried about that at all. So,
right. Yeah.
So,
yeah, checklists I think can help cover all the bases, and that really could be, your workplace violence committee can come up with that, can help come up with that. Even to the point of, do we need peer support? Do we need a critical incident stress debriefing? The checklist doesn't have to be absolute. It can be, this is what maybe you want to think about. After an event happens. I mean, because we do this, I think, with patient safety too. It's like, okay, an event happens. Okay, we need to check these boxes, make sure these things happen. I think another thing we can do better job is documenting our investigations for workplace violence. At least that's one of the opportunities we've discovered in our facilities is we have another thing that could help our leaders is ideally having one reporting system where you can report, your patient safety incidents as well as workplace violence, and maybe ideal that would flow into your workers' comp claim system as well.
That'd be nice.
That would be nice, but the cards are stacked against us for that.
For sure.
And education, I think, for our leaders is, just as important as education for our caregivers. Years ago, read in a study that ideally the leaders, managers would get the same training as their caregivers do. So they know exactly what, is acceptable, what's not acceptable. Everybody can be on the same page. How we did it at one facility too was we trained security and healthcare staff in the same program.
I am a big fan of that. I'm a big fan of that because we did the same thing at an old facility that I was at, where we went, we had CPI. We had CPI, which is just one of the brand name, of one of the violence prevention or violence mitigation. I don't know what they call it these days. Programs, not in my mind, the most effective one. And we switched to another one, and that other one, one of the things they recommended is they recommended like train security and train the nurses so that they work together. Correct. They should have the same training. They should be on the same page. They should know. So you can see the moves, and I'm just doing my little air quotes because, when I say moves, it could be like physical moves, or it could be like, hey, I see that you're upset. Can we talk about this? It could be that, that kind of verbal judo moves as well. Mm-hmm. But so that when they seen it, they recognize where they are in the process, and they can just come in and say, okay, oh, here's where we are. So we're just, trying to get this guy de-escalated. And there's so much opportunity and so much chance for just camaraderie and building trust and knowing that, hey, you know what? I know what you're doing when you know what I'm doing. And one of the most important things it did that I thought was one of the things that drives me crazy in a crisis is everybody tries to talk, right? Like you'll have everybody wants to be like, oh, dude, hey, it's okay, man. You're okay, bro. We're going to take good care of you. And reality is the more voices they hear coming at them, like sometimes that doesn't help. Where one of the things that this program that we had said, one person gets to talk. The other people can stand there. They should be silent. They can, ask if answer if asked. But for the most part, they should stand there quietly and be ready to act, and have one person talking, and be able to recognize that if me and you are there talking to somebody, and I go, wow, I don't know if Bill's having a bad day or something, but he is just not being therapeutic with this guy at all. And that sounds so cheesy. It just makes me cringe just to say that. But the reality is like, hey, this isn't going well. Bill is not doing well with this patient. Let me step up and see if, hey, I can go, let me step up and see if I can, jump in and maybe something will be less triggering to me. And I'm not angry because I didn't have to just run after this guy. Right. Like, so maybe I could be a little bit more therapeutic. Yep. So.
Yeah, and I've seen that in programs where you have like a tap out program or tap out. It's like Dr. Armstrong needs to see you out in the hallway, and that the Armstrong, Dr. Armstrong is the code word, and hopefully you just don't have another Dr. Armstrong in your building. But but it's a code for, hey, you need to step out. Let's switch roles.
Yeah, maybe it's time to step away. The program at the hospital I was last at, it'd be like, hey, they'd say something about CAR, and I forgot there was an acronym for CAR, and it was like, I don't even remember. It was like, check your center, or check your attitude, check your something. I don't know, whatever it was. But it was just a little trigger to say, hey, you know what? Maybe you're not doing real well.
Yeah. Yeah, and I think there's immense value of, look, it's going to happen in the ER. It's going to happen in the emergency department. Violent. So might as well have a plan for it, and we might as well train together.
And it happens that when you go from kind of being more therapeutic or more effective to less effective, happens to different people for different things. I mean, something may trigger you for whatever reason. Like you'd be like, oh my gosh, like I am not doing well with this person. Like this girl looks like my sister who gets on my nerves, right? Like whatever the case may be.
Mm-hmm. And how often we're exposed to workplace violence affects our response too. So that's another thing to consider. If you're like, well, maybe that wasn't handled very well, consider, that would be another thing that can help leaders is consider how, like if this caregiver has been assaulted 3 times in the last month and you're worried about their response, it might be time to, support them. They might need some time off. You might need to encourage, taking some leave to help support them, because that's not normal.
Yeah.
To be exposed to violence that much is really not normal. And we know the public has no idea. Right?
Not a clue. Not a clue. It reminds me of this whole, right now everyone's, talking about how traumatized they are having witnessed CPR during this football game recently.
Yep.
And they're like, oh my gosh, this was so triggering for these people. And oh my God, they were seeing this horrible thing. And I'm like going, like, that was 4 out of 4 days last week for me, that I was witness to, part of, involved in CPR. Going, I'm okay. And I'm as okay as I'm, ever going to be. Like, okay is a very relative term, but
right.
But the reality is like what nurses go through every day. Like the public has no clue. And that includes both, with the traumatic stuff we see, but also with violence. So
definitely is a tough time in healthcare right now. I've even heard that, up to 60% or more of some, emergency departments have staff that are less than 2 years old. So, how do you think workplace violence is going to affect them? Because they haven't been exposed to it and don't know how, sometimes we learn how to self-regulate in the moment. and it takes, like I said before, sometimes it takes time and experience to really develop your own set of skills that are the most effective, at least for you or the situation, and not get into trouble. So
absolutely,
it's a call for our leaders to be sensitive to that, and consider how much you're training, how much you're exercising. Maybe once a year, once every 2 years is not enough, and you need some refreshers. And maybe you need some simulations to go through some simulated events with security or with whatever response team that you have. There's BERT teams is often cited, behavioral emergency response teams, or, you could call, even after the fact, there's Code Purple where you come in and support the staff. But, I think there's value in practicing together, really.
100%. 100%. As we kind of wrap up, what other recommendations do you have for leaders who are trying to support their staff in taking care of these patients, making sure they have the tools they need to, 1, keep them safe, 2, keep the patient safe, and 3, just keep the organization safe? What recommendations do you have for leaders trying to do the best they can?
Yeah, I would say if you feel that you need more support, ask for it. Ask your, your one-up, your chief nursing officer, your director, however your structure is. Ask for it. It could, I would imagine that most hospitals have some sort of workplace violence plan now. But if you don't, start the process. I would just say, if it's a tough time for our staff, it's definitely a tough time for our leaders.
100%. So
I would, just reiterate self-care in there and make sure that you get it. Because I can't imagine the stress of being a leader responsible for a unit 24/7.
It's having done it, it's a little overwhelming.
Yeah. And I would just encourage, participate as best you can. Knowing, I know schedules and competing priorities and meetings, but have a seat at the table. And, I even to the point of bring your staff to the table with you. Because
love that idea.
Leadership can be like one level removed from the bedside, but I think the input of your staff, it's the same with patient safety. It's like we call it the sharp end, right? If you look at an upside down triangle, all the things that influence safe patient care, where the bottom part of the triangle, the tip, is where the care happens. We call that the sharp end. So the sharp end typically knows what could fix this issue. So trusting the staff and involving them in the process, I think, it could help take some of the pressure off the leader as well.
100%. So, well, Bill, this has been a great discussion. I look forward to having more discussions with you about this. This is a topic that, we'll cover on the podcast, I'm sure, many, many more times. And there's still a lot to talk about. So
still a lot to talk about. Yep.
I really appreciate you taking the time to spend the time with the audience and be here. I can't thank you enough for that. And I know the audience is looking forward to hearing more.
Thank you. Appreciate the opportunity.
Thanks so much.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.